Have you ever wondered why some trauma surgeons carry a scalpel in their pocket? It's for nerve-wracking situations just like these. Can't intubate, can't oxygenate scenarios are rare emergencies that require immediate action. Whether you're a resident or an established surgeon, the inability to secure the airway is downright frightening. If you can stay level-headed and remember a few key steps, you will greatly increase your chances of success. First, gather supplies. To perform an emergency cricothyrotomy, you only need 3 pieces of equipment: a scalpel, a bougie, and an endotracheal tube. If you happen to have immediate access to an emergency airway tray, use it. It will have useful instruments like a Wheatlander retractor, hemostats, a trachea hook, and a trousseau dilator. Now, identify the anatomy. Find the thyroid cartilage, cricothyroid membrane, and cricoid cartilage by palpating the anterior neck. Anatomically, the cricothyroid membrane is the most prominent, which makes it easiest to access in an emergency situation like this. To improve exposure, we recommend placing a bump under the patient's shoulders whenever possible. Next, make a generous midline incision over the cricothyroid membrane. This is not the time to skimp on exposure. Remember, these situations are often chaotic. The patient is desatting, the airway team is frantically making attempts at oral tracheal intubation, lighting is terrible, you may not have all the equipment you need, and more times than not, the patient has a short, thick neck that makes exposure very challenging. While it is an option, a horizontal incision is less versatile and may result in bleeding from the anterior jugular veins. Using blunt dissection, expose the cricothyroid membrane and make a horizontal incision through the membrane with a scalpel. Using the handle of the scalpel, a hemostat, or even your finger, enlarge the opening in the cricothyroid membrane and advance a bougie into the trachea. Now, pass an endotracheal tube over the bougie and into the trachea. For most adults, a 6 mm endotracheal tube advanced 6 cm is ideal. Inflate the endotracheal tube cuff and confirm correct placement using a combination of auscultation, chest x-ray, CO2 calorimetry, capnography, and/or bronchoscopy. Success! You've secured the airway. Now, don't let all your hard work go to waste. The easiest way to ensure the tube stays put is to suture it in place. Have you ever